Sure. Okay, this just talk about cortical regions influencing movement. You'll get more about this kind of concept in the spring semester. Dr. Raddick teaches motor learning. Okay? But these are all the cortical regions that are going to influence movement. What's involved in that? And let's start out by labeling a few things. So this is just the standard boxing glove. If I draw this little line in here as a quick review, what's that? That is my central sulcus. Awesome. Okay, which lobe is this up here? Frontal. Okay, coming down here, which lobe? Temporal. Okay, back here, what's that structure? That's your cerebellum. Okay, way back here, occipital. Okay, and then right here behind the central sulcus is your parietal lobe. Okay, so starting out with what we know. The other thing I'm just going to draw in here now is this structure that we've talked a little bit about so far. Big old nucleus involved in somatosensory processing. That is your thalamus. Okay, now a couple of things to start out with. I like to start with what you know. We just did that with some labeling. And then right in front of the central sulcus, you have a really important gyrus that's involved in movement. Does anybody remember the name of that one? Your precentral gyrus. Also, it can be called your primary motor cortex. Same thing. So all these words mean this structure right here. This can be your precentral gyrus. It could also be your primary motor cortex. I may have said that in talking about it previously, but it's the place where your upper motor neuronal cell bodies reside. So you've heard both of those before, and there's one more that you may see or may not see in your future. It can also be called M1 for motor 1. That's your primary motor cortex, or M1. Okay, so far, nothing new except M1. Then moving on back, just behind the central sulcus, you have another important gyrus. This is your post-central gyrus. So it's got we can call it a post-central gyrus. Or we could also, same thing, it's also known as, it's your primary, it's your somatosensory cortex. Okay, so that gyrus that's just behind the central sulcus, you can call it your post-central gyrus. You can also call it your somatosensory cortex. I think we referred to it as both previously. Another new way to refer to it is S1, okay, or your primary somatosensory cortex. Okay, nothing too major thus far. Now moving, let's do that orange. New stuff so far? there's another space. It's going to be in front of the precentral gyrus, still in the frontal lobe. Okay, I'm going to draw this little box right here. And this is orange. You can make it whatever color as long as it's trying to keep the reds kind of together as far as motor is concerned. Okay, this new little box that I've drawn is called your premotor cortex. So that's your premotor cortex. And this is abbreviated PMC. Okay, your premotor cortex is going to be responsible for receiving a lot of information from other parts of your brain and then relaying that information to your primary motor cortex as far as whether or not you can kind of draw them as we go. Area just above the premotor cortex, still in front of M1 here, is going to be another new region to consider, still in the frontal lobe, so still has to do with motor. It's your supplementary motor area. Abbreviated SMA. Okay, so two new regions, just still in the frontal lobe. Your premotor cortex is just below your supplementary motor area. And then this is what we have for motor. And then moving back here, thinking about the somatosensory information, there's another area of interest that's in the parietal lobe. So you're still thinking somatosensory information. Here. And this is going to be your posterior parietal cortex. So sometimes you might see posterior parietal cortex. Other places you might see posterior parietal association area. That's the same space. We'll talk about that a little bit more next year. This is your posterior parietal cortex. I'll just abbreviate that as PPC. So either posterior parietal cortex or posterior parietal association area. Two words for the same thing. All right. Moving on down, there's one thing that we haven't talked about yet that we will when we get to a later portion of this course, and I'm going to represent these structures here just as a circle. It's just going to be a purple circle. We talked a little bit about them being important for setting the boundaries for the internal capsule previously in the last class, along with the lateral ventricles. I'm going to represent these as purple circle are just going to be your basal ganglia. Does anyone know a disease process associated with a problem in the basal ganglia? Not Alzheimer's. That's going to be a problem in the frontal lobe. No, there's no basal ganglia syndrome. Nobody's Parkinson's. Yeah, Parkinson's is going to be associated. So Parkinson's is a problem with the basal ganglia. This is one of those movement disorders. So it's Parkinson's disease, that's the most common, and then there's also Huntington's disease. We'll talk about those later on when we talk about the basal ganglia. Okay, but all of these are involved in contributing to the control of movement, or giving some information for the control of movement. So what happens is that you have the premotor cortex in the supplementary motor area. Information or somatosensory information, everything goes through the thalamus. We've seen that previously. So that information that's coming from the thalamus is actually going to feed into both the premotor cortex as well as the supplementary motor area. Okay, providing sensory information. And then you're going to also have the basal ganglia feeding information into both the premotor cortex and the supplementary motor area. Okay, basal ganglia are going to be mostly involved in the amplitude and initiation of movement, which we'll see later. But they need to convey that information to the premotor cortex and the supplementary motor area. And then there's one more structure that's involved in balance and coordination, and this thing we talked about just briefly called non-conscious proprioception, or the so your ability to know where your joints are in space three-dimensionally without you even thinking about it. It's automatic, and it's automatic due to the structure back here known as the cerebellum. So the cerebellum is also going to automatically feed information right into that premotor cortex as well as the supplementary motor area. So this is all information coming in about the state of things in the rest of the body. Okay, and then that information received by the premotor cortex is then fed in to the primary motor cortex. Okay, and the supplementary motor area does the same thing. It feeds information in the primary motor cortex. Okay, you know, a lot of important information is coming in as far as balance and everything. So as far as the cerebellum is concerned, and the motor cortex's job is to say, okay, we're going to move, right, or we're not going to move. It has that choice. So if you're walking along, and I don't know if anyone's ever done, I'm sure you've done it before. If you're walking along and there's a hole in the dirt in front of you that you haven't really seen, or maybe it's covered by grass, and as you're walking, you know, walking is like you're going, not really thinking about it, but you hit that hole, and then you stop walking, right? Because something changed. That's the cerebellum information coming in from the cerebellum, and also the information coming from the thalamus, the somatosensory information coming in from the thalamus. They're saying, well, something changed, stop, you could get hurt. Okay, so that information is processed here, and then if everything's good, the go-ahead is given to the primary motor cortex to go forward. Make sense? All right, so thinking about the posterior, that's information feeding into M1 directly. There's also the somatosensory information coming up, again from the thalamus, is going to feed into the posterior parietal cortex. Okay, posterior parietal cortex, its job is to make sense of the information coming in. In addition to coming in, the main somatosensation coming from the body, you also have this information coming back here from the occipital lobe. Does anyone remember what's processed in the occipital lobe? Vision. Awesome. So visual information. All this visual information is coming in, processed in the occipital lobe, and then that visual information is also transported to the posterior parietal cortex. Okay. That posterior parietal cortex makes sense of that information, and then sends a go-ahead to the primary motor cortex saying it's okay to fire, okay, or not fire. Examples of somatosensory information coming in, so let's say SCT, pain, temperature, whatever. I like to cook, do a lot of cooking, so you know I have a pot with a cast iron pot on the stove. Sometimes I forget to grab the hot pot. So my intention is to grab the pan and do something with it, but if I don't have that pot holder on my hand, I'm going to think I'm going to do that, but I feel the pain coming in and I just pull back, right? That's the job of the somatosensory information saying don't do that. Okay, and then an example for the visual information coming in the posterior parietal cortex is it has to process. I could be running along on a trail or walking along on a trail, regardless, and you know, not really thinking about anything else, and then I see this great big black snake come out in front of me. I'm gonna stop walking, right? My visual information has said, we're just gonna stop right here. But it's not really a thinking process, it's just, you just stop, okay? So those are all the pieces that are involved in controlling motor functions. We'll get into a whole lot more detail later on in the semester. We're going to talk a whole lot more about how the cerebellum works. We're going to go through in excruciating detail the visual pathway, because that's super important, as well as the basal ganglia. Questions about that? Yes, Sarah.
Are you able to move your mic a little bit further away from you?
Yeah. Sure.
Thank you.
Does that help? Is that better?
As long as we can still hear you.
Okay. Was it coming across too loud or
Yeah, it was just popping a little.
popping? Okay.
Yeah.
Well, thank you then. Any other questions? Is that good? All right. Let's go ahead and move on. To descending motor tracts. We have when I did the great big spinal cord overview earlier, we looked at these, but I'd like to start out with just a basic overview of the ones that we're going to be talking about. And to make things simple, to see what crosses over and what doesn't, I always like to put my midline in here. Okay, what you're looking at is just a basic frontal section. And we had talked about the upper motor neurons, or the neuronal cell bodies that are located in the primary motor cortex, and they would be positioned right about here. So this is just an upper motor neuron cell body. There. Okay, there's your upper motor neuron cell body sitting in M1. And that upper motor neuron cell body is going to send out an axon. That axon is going to travel down through the midbrain, through the pons, all the way down to the level of the medulla. Okay. When we get to the level of the medulla, we're going to decussate to the opposite side. Okay, and then axon continues on down, and at the appropriate spinal level makes a synapse with the lower motor neuron. Okay, here's your lower motor neuron cell body. I'm trying to think about how to make it purple. So here's your lower motor neuron cell body. Okay, and then that sends out axons that have the job of innervating skeletal muscle. So innervating skeletal muscle, so think voluntary movement. Okay. So it's under conscious control. This is your lower motor neuron, axon. Now coming out of this upper motor neuron cell body, does anybody remember the name of this tract coming down, starting in the cortical region, going down to the spinal cord? Corticospinal, that's it. So there's your corticospinal tract. So corticospinal tract has another name. Does anyone know the other name? It's called the pyramidal tract, like pyramid. I'm going to find out why they call it that today. So here, corticospinal tract, CST, pyramidal tracts, all talking about the same tract. Pyramidal, like pyramid, P-Y-R-A-M-I-D-A-L, pyramidal tract. or corticospinal tract. Okay, this is going to be the main, this is the pathway for voluntary movement. Okay, thinking you're going to move and then you have control over that thought. We talked previously about another descending motor tract. And for this one, there's going to be a nucleus here that's present in the midbrain. Just remember that nucleus name, anybody? It's going to be your red nucleus. Okay, that red nucleus sends out axons that decussate immediately. So you're going to come all the way across, and then they're going to come down to the appropriate spinal level and synapse with a lower motor neuron here. Does anyone remember what kind of motion is associated with the red nucleus and the rubrospinal tract? Yeah, that's going to be upper extremity flexion. Good. So this is going to be upper extremity flexion, and in humans, in particular, elbow flexion. Okay, and as I said, this is going to be your rubrospinal tract. Because we start up here in the red nucleus, rubro, and then end in the spinal cord, so rubrospinal tract. Moving on down, so start up in the midbrain. There's another motor tract that you need to be aware of that has its origin here in the caudal pons. And I usually represent that as like a little kite. That's going to be, this is your vestibulospinal tract, so this is your vestibular nucleus. Your vestibular nucleus sends out axons a little bit differently than the red nucleus. Instead of being contralateral, these are just going to come down and stay ipsilateral. So we're just going to come straight down to the appropriate spinal level, stay ipsilateral, no decussation for the vestibular nucleus or the vestibulospinal tract. No decussation. Okay, we're just going to synapse at the appropriate spinal level here and are involved in innervating. Yes, Anna. That's your vestibular nucleus. Vestibular nucleus. Involved in figuring out where your head is in three-dimensional space and head movement. Okay, axons coming out. What does the vestibulospinal tract, what is that specific for? Does anyone remember? Yeah, extensor musculature. So that's going to stimulate extensor muscles.
That's upper and lower.
Think more postural. Yeah, upper and lower extremity, but think postural. Postural muscles. So if you're upright against gravity, you want your extensors to fire. Okay, there's only one more. Last one is going to be, make it, I guess pink works fine. Down here, so we have midbrain, one in the pons, there's last ones in the medulla. This is just going to be a diffuse bunch of neuronal cell bodies that are hanging out at the level of the medulla. They're involved in conscious awareness, awakeness, and they're going to send out axons that stay ipsilateral. They don't decussate. Synapse at the appropriate spinal level. Okay, this diffuse set of nuclei, does anyone remember their name? Yeah, that's the reticular formation, great. Okay, that's your reticular formation, which makes this your reticulospinal tract. Starts from reticular formation to the spinal cord.
Is that on the right or the left side?
It stays ipsilaterally. It stays ipsilateral. So I started out on the person's left side, and it stays on the left side. It does not decusate. Neither the vestibulospinal nor the reticulospinal tract decusate. Both the corticospinal tract and the rubrospinal tract decusate. Okay, so what reticulospinal tract, what does that innervate? Does anybody remember? Again, it's going to be extensor muscles. So if you're awake and conscious, your extensor muscles are firing. Okay, if you're upright against gravity, you're going to cause your extensor muscles to fire. However, you should be aware of the fact that the red nucleus, or the rubrospinal tract, vestibulospinal tract, and reticulospinal tract are not under conscious awareness. Okay, they're controlled cortically, but not consciously. Okay, there are things in the cortical region that dampen the effects of these to not be. You have to. They happen automatically. Okay, but they're under control from other regions. Yes, Justin.
Which ones again?
Okay, the rubrospinal tract. See how they don't reach the level of the cortex? So the rubrospinal tract, vestibulospinal, and reticulospinal tract are not under conscious control. Okay, there are regions of the cortex that are involved in dampening their activity, but that you can't make them fire voluntarily. You can't say, oh, I want my elbows to bend and use the rubrospinal tract. Okay, the only way you can have that happen is using the corticospinal tract, because that's you're thinking about it. It requires conscious thought, has to have the cortex involved. Okay, yes, yeah.
What was the pink one called again?
That is your reticular formation and your reticulospinal tract. Okay, reticulospinal starts in reticular formation, goes down to the level of the spinal cord. Yes, LA.
Is the reticulospinal tract also postural muscles, or is it different extensors?
Yeah, postural is the best way to think about it. So if you're awake and aware, you want your postural muscles to be firing, right? You're conscious. If you're asleep, your postural muscles, none of your extensors are firing. Your postural muscles aren't firing. So like if you fell asleep standing up, you'd fall over, right? That's the way to think about it. Any other questions? Yes, Alex.
When you say your extensors are firing, you're talking mostly like vertebral, posture, and sensors.
Okay, so my quads are firing, lower extremity, my glute max is firing, my paraspinals are firing, and my neck extensors are firing. All of those are firing. And probably if I were walking on all fours, my triceps would be firing. But since we walk upright, we don't get the tricep firing through that track. Does that help to think about postural muscles? So I know that if I get a person upright against gravity and support them properly, just by having them upright against gravity, I can strengthen all of those muscles for them without them doing a thing, but just standing there, supported. Other questions? Okay, those are the basics. These are the ones we're going to go through in a lot more detail today. And moving on, we're going to start with the big one, and that's going to be your corticospinal tract. Again, I have to label my middle so we can see when things cross over. just in general. Just looking at a frontal section, this is a very similar picture that you saw the other day when we talked about the somatosensory pathways. Coloring things, trying to keep things similar. These structures here are going to be my basal ganglia. Okay, one on both sides. Okay, this is part of the basal ganglia as well. That's your caudate nucleus. This structure here is going to be my thalamus. Okay, so far, nothing new. Looking at other things, we also have these. What are these things here? Yeah, these are my lateral ventricles here. Okay, and here's my third ventricle. And then this is my cerebral aqueduct. So that's, just say, ventricles in general, and I'll label the purple as my basal ganglia. So hopefully nothing new so far, and things we talked about before. Up here in the M1 region we have the neuronal cell body of the upper motor neuron. Okay, that upper motor neuron cell body sends out an axon that travels down as the corticospinal tract. We've seen that a couple of times. So it's going to send my axon out here. And note the path of the corticospinal tract. We're going to descend down here, and then we're going to go through this space. Say ipsilateral, okay, go through this space again, and then head down through the midbrain. Does anybody remember what that special space is called? Yeah, here's your internal capsule. So I'll put it in. So both the somatosensory tracts and the motor tracts head through this special space known as your internal capsule. It has special significance that we'll see later on. Okay, so pretty straightforward. Nothing much new. This upper motor neuron cell body sends out axons. The new part is it travels through the internal capsule and then descends down to the level of the midbrain. And then we have the next picture. That is the corticospinal tract decussation in the medulla. Okay, so just like we did with somatosensory tracts, we're going to have that upper motor neuron axon be coming down through the medulla, midbrain, sorry, coming into the midbrain. It's just there for right now. Okay, so this is just.
Dr. Barlow, where is the second one of that? Where's that one at? Like the other packet?
Yeah, there's a whole other packet. So yeah, so hopefully everybody got. Did everybody get two? There's more in the back to it. Emily has some back there. Does anyone else need the second packet? Yeah, there was an issue with the Xeroxing, so we got two this time. Does everybody have what they need to go forward? Okay, great. Now, in looking at this drawing, this is going to be your midbrain. Here's your pons, and here's your medulla, and there's your spinal cord. And again, the axon's going to travel down all the way through the level of the spinal cord. But I added a couple of extra bumps to the medulla to give it a little bit of a definition. It's actually what it looks like. What I'm trying to represent here three-dimensionally is two bumps. There's two on either side. So the medulla, one bump would be here, and then the third finger would be a second bump. Does everybody see that? So there's like a bump. That's what these are. So there's bumps. 2 bumps on either side. Okay, that has special meaning. The bump, if I were my third finger, the bump most lateral here is known as your olive. Okay, it's known as the olive because it's home to the olivary nucleus. It's going to become important in when we talk about cerebellum. And the guy that taught me neuroscience emphasized that he really liked martinis with olives. So if anyone likes martinis, that's how you remember the olive. You have to have your olives with your martini. Okay. Now, that outside bump is the olive, and it's bilateral, one on each side, so it's there and there. Okay. There's this middle bump right here. Does anybody know the middle bump's name? That's a pyramid. Okay, so the outermost bump is your olive, and the innermost bump is your pyramid. Like I said, that outermost bump has the big fat olive under it, so that's what makes it bulge out. Well, the innermost bump has the pyramid, and what happens within the pyramid is this axon coming down through the midbrain, the pons, to the level of the medulla in the pyramids. What happens is something known as a pyramidal decussation, hence the pyramidal tract. So at the level of the pyramid, we decussate to the other side. And interestingly enough, not all axons here are going to decussate to the other side. It's only about 90%. I'll put that in. Okay, 90% decussate at the level of the pyramid, and then once they decussate to the opposite side, then these 90% that decussated travel down as the lateral corticospinal tract. So here, this is just the corticospinal tract. But once the 90% that have decussated, they now become that lateral tract that we showed before when we looked at the cross section. This is your lateral corticospinal tract. Okay. So thus the question becomes, what happened to that other 10%? That other 10% that was way out of the norm doesn't decussate. It just travels straight on down through the spinal cord. Okay. So this is the 10% with no decussation. And they travel down through the spinal cord as the anterior. If you remember, there were 2. There was the lateral corticospinal tract and the anterior corticospinal tract that we looked at.
Can you read that again?
I'm sorry, can you say that again?
Can you read that again, the one you drew?
Yeah, 10% with, see with the minus, with no decussation, and they become the anterior corticospinal tract. So the 90% so above the level of the pyramids, it's just the combined corticospinal tract. You get down to the level of the pyramids in the medulla, 90% decussate, and then travel down the spinal cord as the lateral corticospinal tract. 10% that don't decussate just keep coming straight on down, and they're the anterior corticospinal tract. We'll look at those again here in a minute. Questions so far? And these just keep traveling all the way down. We're going to finish off the picture. Okay? And moving on to the next picture, so I'm just going to continue this on right here. The next picture is going to continue on. We have the spinal cord, and then this is just a transverse section of the spinal cord right there that we've seen before. Start labeling. So when I talked about when I said the lateral corticospinal tract, so if you remember, here's my dorsal columns, this is lateral, and this is anterior, okay? My lateral corticospinal tract is positioned bilaterally right about here, okay? And that's going to be the big one, like I said, for voluntary movement. And then my anterior corticospinal tract was in a different space. I'll make it probably fine. I'm going to say my anterior corticospinal tract, if you remember, was right here, bilaterally. We looked at those previously when we looked at cross sections through the spinal cord. And kind of orient you a little bit more. So this is my dorsal gray horn. And here's my ventral gray horn. Okay. And for now, I'm just going to go ahead and put a couple of neuronal cell bodies, or lower motor neurons. I'm drawing very specifically here, so I'm going to have two up here. These are lower motor neurons. There are going to be two that are a little bit more dorsal, and then two that are a little bit more ventral. And those are just my lower motor neurons. We'll label them in a minute. Okay, everybody see where we are? What happens? So that's where your alpha motor neurons or lower motor neurons reside in your ventral gray horn. And if we want to continue on the travel from above, the 90% that decussated are going to be over here. They're going to travel through the spinal cord, and they're going to travel through this lateral corticospinal tract. Okay, these are the 90% that decussated. Okay. Okay. Once they get to the appropriate spinal level, they're going to come out of that lateral corticospinal tract in synapse with a lower motor neuron, or an appropriate lower motor neuron. We got it? See where we are? What happened? All right. And then coming down on the other side, we have the 10% that didn't decussate, right? They're going to stay ipsilateral to where they started in the cortical region, but when they come down here, they're traveling through this anterior corticospinal tract, okay? When they get to their appropriate spinal level, they're going to decussate at that spinal level and synapse on a contralateral lower motor neuron. Okay, so the anterior corticospinal tract, the lateral corticospinal tract, that 90%, they decussated in the medulla, in the pyramids. That 10% decussated at that spinal level. Yes, Alex?
For the anterior, does it matter which one of the neurons they're decusating or synapsing at?
For the purposes of our purposes, no. Nope. In reality, it's more axial muscles, but you don't need to know that. You just need to know that the majority, 90% decussate at the level of the pyramids, and the 10% decussate at this spinal level, at the appropriate spinal level. Okay, any other questions? Do I see that? So, pretty straightforward, and then the one more important thing that you need to know about this slide is that the cell bodies, these neuronal cell bodies of the lower motor neurons in the ventral gray horn exist in a somatotopic relationship. Okay, so I'll write that over here. These lower motor neurons, cell bodies, in the ventral gray horn have a somatotopic relationship. Okay, so they have a specific position with the body. Alex? Oh, yes, thank you. So what you see with a somatotopic relationship is that there's, and the way I like to remember it is this, okay? If you think about, flexing your muscles or whatever, upper extremities work, good to see it, okay? If I have my arms flexed like this, like Popeye, right? The things on the top are the flexors, the things on the bottom are your extensors. So everybody see that? So flexors are on top, extensors are on bottom. So if I had to label this, if I have to label these motor neurons here, this would be biceps, right? And then this would be triceps. Everybody got that? So my biceps are on top, triceps are on the bottom. Okay, that's one relationship. So I'll put that over here. So I'll put flexors on top. Okay, and then the other thing to remember is that there's the proximal musculature is more medial. So biceps and triceps here more medial, but then as we go distally down the arm, that's going to be more lateral. So if this is biceps, let's say this is wrist flexors, wrist or finger flexors. And then this would be wrist or finger extensors. Okay, so proximal musculature is more medial. Distal is more lateral in the ventral gray horn itself. Does everybody get that concept? So just think about it this way. Sometimes people get confused if you think about a leg. I mean, you can think about, the extensors being on the bottom, but you'd be upside down. But then the really confusing part is when you think about the hamstrings being opposite the extensors. Well, the hamstrings can also be hip extensors. So don't think about lower extremity, think about upper extremity. Okay, so first.
So, somatotopic relationship is really just saying that it's placement.
Placement, so kind of backwards of that. So like the function determines placement. Okay? Same concept, but just another way to think about it. Yeah, Ian?
So we're not saying that, like, that one specifically has to be biceps, we're just saying that it would be a flexor or...
It would be a flexor, and it'd be more of a proximal muscle, as opposed to a wrist or finger extensor, which is for flexor, which is going to be distal and more lateral. Okay? So yeah, I'm just labeling it as something, just so they get the concept. So everybody see that? Understand what's happening? Yeah? Okay, let's go ahead and take a 10-minute break then.